Okay, colleagues and friends, good morning, good afternoon, good evening, wherever you are. Today we are in another webinar in the series of the WEBi series that Infinite used to do over the last 2.5 years. And today, really, we are going to tackle a very important topic indeed, which is the investing in public health workforce capacity in the Eastern Mediterranean region, the progress, lessons, and the prospects. I think this is a quite important topic, and today we have a distinguished panelist in this webinar. And before starting introducing, I have just a few words to say. First of all, we would like to express our sincere condolences to Dr. Anne Pirochet, who should be supposed to be one of the panelists today, but unfortunately, she lost her father just a few days, and we really express our sincere condolences for her to this tragic events and the tragic times, and wish her all peace indeed and all good time. And hopefully she is going to pass this very tragic and difficult times. This topic, indeed, the public health workforce capacity in the Eastern Mediterranean region is quite important over the last times. Really, investing in health system in general refers to the allocation of resources to improve and maintain the infrastructure, technology, personnel, and the processes that are necessary for delivering healthcare services. This includes not only the building of and upgrading of health care facilities, purchasing of medical equipment, but also training of healthcare providers and implementation of effective healthcare policies, with the ultimate goal of investing in health system is to enhance access to quality healthcare, reduce health disparities, and improve health outcomes. Investment in public health workforce capacity in the Eastern Mediterranean region has led to significant progress, including improved training and education, better health system, and stronger health information systems. However, there is still much work to be done, and continued investment in public health workforce capacity is needed to ensure that the region can meet the health needs of its population in the future, with a focus on workforce development, like developing and training existing staff, as well as attracting new talent to the field. This includes programs such as field epidemiology training programs, mentorship programs, professional development opportunities, and workforce strengthening initiatives. Collaboration with academic and research institutions is critical to ensuring that public health professionals are equipped with the latest knowledge and evidence-based practices. This collaboration should include also opportunities for continuing education, research opportunities, and the development of training programs, like in the International Academy of Public Health, where it is integrating the technology and innovation in public health workforce to enhance service delivery, improve the quality of the training to ensure that workers are well trained and adequately staffed public health workforce, since it is essential for detecting, responding to, and controlling outbreak of communicable diseases and addressing chronic diseases and increase efficiency as well. Investing in public health workforce capacity in the region has numerous potential benefits, including improved health outcomes, increased access to care, strengthened health system, enhanced economic growth. However, there are still a good number of challenges as well. Among these is the political and economic stability or instability in the region, as well as the availability or unavailability of resources and investment. So hopefully in this webinar, we are going to address some objectives. Among these, number one is to provide a review of the current situation, issues and challenges related to public health workforce capacities and public health education and the practices in the Eastern Mediterranean region. Secondly, to take stock of the progress in public health workforce capacity and explore the existing solutions like the field epidemiology training programs. Also, to introduce new initiatives and innovations aimed at promoting public health workforce education and capacity, and finally, to propose relevant recommendations and solutions to address the gaps and challenges in investing in public health workforce. We have three speakers indeed, and I'm going to start first of all with the Professor John Duncan Middleton. And Professor Middleton, he's a fellow faculty of public health and fellow Royal College of Physicians. He's the president of the Agency for Public Health Education Accreditation, AFIA, immediate past president and vice president of the Association of Schools of Public Health in European Region, ASFA, and past president UK Faculty of Public Health. He was director of public health for Sandwell and the West Midlands of England for 27 years. His professional interests are in community safety, community development, climate breakdown, and environment protection. On the other side, he is also blues harmonic players with Dr. Harp's Medicine Band, albums on Apple Music and Spotify. This is very interesting, President Middleton. Professor Middleton, he is going to address the public health education and the practices in reference to essential public health functions. Professor Middleton, you have 20 minutes to present your slides, and allow me, if you go just to close, I will just say that you have 2 or 3 minutes in case you have longer time. So please, the floor is yours. And just one point for the colleagues, if you have any question, you have a Q&A box in the lower part of your screen. So please, if you have any question, just put it there, and hopefully you will have time to address all the questions that you have raised. Professor Middleton, the floor is yours, please.
Thank you very much, and thank you for those kind words of introduction. And it's my great pleasure to be with you all here today for this webinar series. The essential public health functions are something which all of the regions of the world have been looking at in various forms. And the most recent is the national workforce capacity for implementing essential public health functions, including a focus on emergency preparedness and response. This from a steering group, a working group of the WHO, which was launched in May last year, and there was an action plan in October. And this is a very important document that I commend to you. Within it, there's a sequence of WHO papers that have led to this, one of which was published in 2021. And that table there shows 4 of the regions of WHO and how they have looked at essential public health functions. The reassuring thing about this is that although the words are different, in many cases, the functions are identical. They all include surveillance and population health, monitoring and response to health hazards, assuring governance, efficient and equitable health financing, health protection and health promotion, and disease prevention, and also advocacy and communication and social mobilization. So there's broad similarities between all of these. That's the European version of it, and there were 10 in the European essential health functions from a very long time ago, from 2012. What I think is interesting now in the WHO's version is 2 additional areas which I think are very important. One of which is...
Excuse me, Professor Middleton, can you please share your slides?
Oh, Christ. Sorry. I thought I was. Never mind. I can't... I'm going to have to start again, I think, because I've got the slides on my screen, but obviously you haven't. Sorry, let me go back.
That's okay. Would you like to share it from our side?
Can you see it now?
No, not yet. but they can help you from Dan and her colleague can give a hand. We can share it from our side.
It's my Zoom I've lost. I can't see myself. Let me try again.
Yes, yes. You can, yeah, that's perfect.
Yeah, but if you do that, you're going to have to change, move it for me, I think, aren't you? Yeah, I'm going to have to tell you every time I want a slide changed, and that's not going to be very easy. Can you just give me one moment and I'll try and pop it up again. Sorry about this, folks. If you just give me the... Okay, well, let's...
That's quite, you could just say it next time, they will do the job. No worries.
We just share this. Right, okay, I've got it. How's that? Is that it?
Yeah, perfect, perfect. Thank you.
Marvelous. Right, sorry about that, folks.
No, that's okay.
Let me start again. So the national workforce capacity with a focus on emergency preparedness and response is the latest version of reports from WHO Global, launched on the World Health Assembly last May with an action plan in October, talking about essential public health functions. In the document, it refers to earlier World Health Organization documents, which all show broadly similar areas that count as essential functions: surveillance of population health, monitoring and response to health hazards, assurance of governance, equitable financing, health protection, health promotion, disease prevention, advocacy and communication in social mobilization, and assuring public health workforce and research. And these, as I say, are broadly similar across many of the areas of working parties of WHO regions across the world. These are the European ones that have been in place since about 2012. And really the only difference is now is that WHO have brought in two more essential public health functions. And those, I think, particularly relate to health services, public health. So assessing the quality and the equity of health services and assuring access to healthcare and assuring availability of medical products. So those are important additions, I think, to the essential public health functions. In that WHO work, there's further work being done now to define the sub-functions of the essential public health functions, to look at how we can develop competency-based health education and how we can map and measure occupations that relate to public health. Now, in the work of my own organisation, ASFA, we've also published work with WHO in the European region. The competency framework published in 2020 describes, in terms of context and content of public health, things like the science, the practice, promotion of health, One Health and law and policies and so on. It also describes the interactions that are needed: leadership, collaboration, working in partnership, being able to communicate, expressing and developing a culture of health, and being able to be an advocate. And they also talk about performance and achievement, how we govern ourselves, how there is professional development, ethical practice, organizational literacy. And what is particular about this document, I think, is the way it describes the levels of competence people need, whether they're experts, whether they're prolific, whether they're proficient, or whether they are competent. And that's a very important distinction that we need to develop. Another of ASFA's documents is the European list of core competencies. And that very much is a list of what schools need to teach, particularly for the Masters in Public Health level. And I think that's a very useful complementary document. More recently, in 2022, ASFA again published with WHO in the European region a roadmap towards professionalising the public health workforce. And for me, this made it more a way that I could understand it better. We need a robust, well-resourced public health system, a function and a profession expressed in local, national and policy statements. It's a vision, it's a mission, it's a reason why we need to protect and improve the health of the people and the planet. We also need expertise and we need knowledge amongst our professionals, so we need competencies. What should schools therefore teach? That is the curriculum. Should schools and programs teach it to an acceptable standard? That's accreditation. Should graduates achieve the standard when they have been through the course? That is the qualifications. And whether graduates continue to operate at those kind of standards and whether they develop and achieve experience, that comes through credentials. Do professionals maintain their expertise? Can be found in their public health audit, clinical audit, and in their professional appraisal. And do these professionals fit the requirements of what their employers are asking for in a task? Well, that can come through job task analysis, skills and knowledge frameworks. And do professionals behave appropriately? Well, for that, we need codes of conduct. And are professionals supported in what they do? That comes through chambers, through colleges or associations, however they're described in individual countries. Whether professionals can be removed if they don't maintain the standards or if they break codes of conduct, that comes through their regulatory bodies. And are professionals supported in their terms of conditions of work? We owe professionals to have their own trade union. I'd just like to reflect very briefly on AFIA, the organisation of which I'm president at the moment. AFIA is an agency for public health education accreditation. We operate in six WHO regions, and we're involved in accreditation of continuing professional development, curriculum validation at master's and bachelor's level, program accreditation in schools of public health, and also institutional accreditation, where we look at the whole practice of a school or college or department of public health. And we seek to use global standards. We are a peer supportive mode of operation. We don't prescribe a very strict and rigid way of doing accreditation, but we do use a peer-led approach, and I think we are widely valued because of that. And some of our activities, you can see there that EMRO is very well represented in terms particularly of continuing professional development, and we're seeking to develop these accreditation programs across the globe. That's very much about the specialty of public health, the skills and standards that we need. Public health is a medical specialty, but it's a multidisciplinary profession, service, and system. We need health professionals from a wide range of backgrounds: medicine, nursing, allied professions, occupational health. And we have also another group of people who've very much formed part of the public health field for many years: environmental health, information science, social care, and increasingly bringing others like teachers and police officers into the fold. But as we move into the 21st century, we need a much wider group: economists, social scientists, psychologists. In my paper in the European Journal in 2016, I talked about the challenges of 21st century public health: ISIS, crop failure, and no antibiotics. And the reality is there that we need the skills of public health, be it in epidemiology and all those essential public health functions, but we need to expand our partnership working, our knowledge of other disciplines, be it the likes of climate science, ecology, even theology. We need to understand why people believe what they believe if we are to communicate better for the various great religions of the world. We've seen in the pandemic that we need those skills of public health, epidemiology, assessment of what's effective, but we also need to work in partnership. We need other disciplines. We need to be able to communicate well, and we need preparedness. In any major disaster, what goes wrong is around procurement. It's around relationships and communications to press and public. It's around people being injured or dying from other emergencies. And it's also around recovery. So we need very much to up our game in all these areas, not just because of pandemic, but also because of other major disasters. Many public health authorities have been calling for a strengthened public health service in the future. This was ASFA's contribution early in the pandemic. The United Nations and World Health Organization are in the process of developing a mandate around a new treaty for pandemic preparedness, which is being somewhat watered down as time goes by. But the early statements and sentiments about that were about much better global collaboration on addressing the problems of a pandemic. The 2021 report of the independent panel also highlighted that need for greater public health capacity, greater investment, greater cooperation, and in the global network for academic public health, of which ASFA is a member, we argued that investment in schools of public health and in education and training was an absolutely vital component. Often people advocate for research investment, but much less so advocating for training and education. But in all those statements of essential public health functions, they're quite light on what they say about law, ethics, rights, and values. Our values should reflect the fact that we are about preventing disease, prolonging life, and promoting health through the organized efforts of society. It is a science, but it's also an art. And we are seeking for health, which is physical, mental, and social well-being, and more than the absence of disease. And we must advocate for health. We must, in the UK, William Beveridge, in the deepest part of the Second World War, talked about 5 giant evils that we should make collective peace with. We couldn't separately make our peace with want, idleness, ignorance, squalor, and disease. And in the 21st century, we have 5 geopolitical evils: climate breakdown and environmental degradation, the potential era of pandemic, the offshoring of wealth, creating extreme inequalities between the super rich and the poor, multinational companies operating in an unregulated way and damaging health across the globe. And we also face conflict, corruption, transnational organized criminality, and we are in the era of disinformation. So we have to have a new skill set, a new willingness to partner. We have to be involved with the likes of vets and the One Health movement. In climate change affects everywhere, and it affects poorer parts of the world disproportionately to the rich. And it shows the interconnectedness of what we operate in. The Syrian war is often given as an example of how drought in the Middle East led to the migration of farmers into the cities, the further enhancement of food shortage, the food riots, the Arab Spring, the conflicts that erupted across the Arab world, and the consequent migration, the rise of populist governments in Europe, and the political backlashes that we've seen there. So we do operate in a difficult and complex world. We know there are clashes over oil, but also the potential for wars and conflict over water. We've seen, and public health has neglected its role in relation to prevention of conflict. That's a statement there from my UK Faculty of Public Health. There is a major need for public health to be involved in conflict reduction and in resolution. The pandemic has seen the explosion of wealth in the super rich, and this offshoring of wealth that we've seen means that governments no longer have the investment available to them to invest in their communities, and we need to address this major damage to our individual health and to our national health. This is an image of 10 major companies that look after most of the food we consume. And if you think that exhortations to health education are going to change what those companies do to damage our health, then I think you need to look more firmly at things like regulation, taxation, and controls on these very health damaging companies. And of course, those companies employ the scientists who obscure that knowledge that we have, who question it, who damage it, who undermine it. And we have to be able to address that challenge of the merchants of doubt. Disinformation is a major factor we know in vaccine hesitancy, but it's also part of this picture of distrust and undermining of professional and expert knowledge. These smug pilots have lost touch with regular passengers like us. Who thinks I should fly the plane? A populist sentiment and one that needs to be challenged. We have to invest in education, and we have to invest particularly in women's education. It's vital for improving health. It's vital for improving the economies of countries. And it's also vital that we as health organisations stand up for human rights and challenge some of the extremes in political systems that are damaging human rights. My organisation, ASFA, has made several statements around the problems of the Israeli approach to the Palestinian community. My organisation visited Gaza in 2014 and witnessed the destruction and the unacceptable face of the Israeli policies. We've also spoken up about the explosion in Beirut recently, And now, of course, the world stands by largely looking at the disaster of Turkey and Syria during the earthquakes. And we have to get to a better global approach to dealing with major emergencies. In a paper in 2021, Enrique Lopes and I talked about how we should be better prepared for pandemic, but the same issues apply with all responses to global disasters, and we need to be better resourced, better prepared, and much more willing to support international effort. And on that score, we've also heard sentiments that about building back in the future. And I say to what? To austerity, poverty, unfairness, environmental squalor, and health for some? I say we should plan for an outbreak of health, and we should be building forward fairer. I thank you very much.
Thank you. Thank you very much, Professor Middleton, for this very insightful presentation indeed. And I will keep the question later on, inshallah. We will have some time to address them. Now I will give the floor to our colleague, Dr. Haytham Bashir. And Haytham is the Executive Director of the International Academy of Public Health. He's also the Workforce Capacity Team Lead at Infinite. He's Assistant Professor at the School of Medicine, National University in Khartoum. Prior to these roles, Dr. Bashir worked as the Director of Teaching and Education at the Public Health Institute in Sudan, and the Director of the Emergency and the Humanitarian Action Department in Federal Ministry of Health in Sudan till 2010. Besides teaching, Dr. Bashir works as a research supervisor and external examiner for many universities. He has experience in designing and implementing education and training program. He has published work in emergency management, capacity building, and training. And Dr. Bashir, he holds a PhD degree in disaster management, a master degree in public health, in addition to the MBBS. Dr. Bashir, he is going to present the field epidemiology training program as an example of capacity building program for the health workforce. Dr. Haytham, you have 20 minutes for your presentation. And again, we will keep all the questions later on after the end of you and Dr. Sheikh Badr.
Thank you, Professor Faris, and it is a pleasure being with you and Professor John. I just wanted to add that I'm recently honored to be a member in the board of directors for EFIA. So thank you, Professor John and colleagues. As Professor John shared in his nice and very informative presentation, he touched on important topics, essential public health functions, public health educations, and other related areas. So what I'm going to share with you in the following few minutes is the example of the field epidemiology training program, well known as FETP, as an example of a capacity building program, and see how it fits what Professor John has described to us. So in my presentation, I will try to explain what is FETP, how does it work, and what impact is being seen by the FETP and still expected, as well as how we can use the example, the model of the FETP to be reflected on other public health capacity building program in order to maximize their impact as well. So I think for those who joined our previous webinar now, they know that FETP is a supervised on-the-job competency-based training and service program. So FETP is not just a training program. It also expands its functions to include service provision. The aim of this program is to create a pool of field epidemiologists and other public health practitioners who can serve at all levels of the health system in our countries. And the FETB graduates are well equipped and competent in mainly managing the surveillance data and studies, investigating outbreaks and responding to public health emergencies, monitoring public health events, and communicate and plan health informations, including scientific writings, evidence generations, and others. So how does the FETB works? Of course, it is designed after the EIS program in the US in 1960s, but the distinguished feature of this program is that it can accommodate all who serve under the umbrella of public health and field epidemiology. For this, we can see this familiar structure of the program, where the 3-month program is mainly for those who serve at the front lines of the health system. The advanced are for more specialized health professionals, managers, and field epidemiologists who serve at the central level, and of course the intermediate, mainly at the governorate levels. But there are distinguished features that define the FETP and differentiate it from other public health programs. First, the composition of the program, where we can see that 75% of the training time is in the field, where the residents, they do things using their hands, and of course, with 25% as didactic sessions in their classrooms. Another important feature of this program is that research is an integral component, but it's mainly operational research directed to existing problems in the health system, and of course, addressing the health priorities of a country. As the percentage of the field is 75%, we can figure that mentorship is a backbone of the program, where residents are guided, supervised, and mentored by experts in the field in order to pass the experience and skills that are not easily being gotten during the or in the classes. As I mentioned earlier, a distinguished feature of this program is service delivery. Many of our public health education programs, they necessitate that the students stay away from their workstations for 1 or 2 years in a time where the Ministry of Health or their employing agencies are mostly need their service. So this program, I think, contributes to solve this dilemma, where the training is being provided while they are doing their duties in their job stations. As Professor, again, John mentioned, the beauty of this program is that it accommodates all those who serve under the umbrella of the public health, whether the medical doctors, nurses, vets, lab technicians, and many other health professionals. Because we usually follow a standardized curriculum to the FETB, however, each and every country, they tailor this program or customize it to suit their or match their national context and priority health problems. And why? Because this program is flexible and designed, I think, in an efficient way that make it easy to be customized as needed. And recently, following the COVID-19 pandemic, MFNet could customize this program specifically to tackle the issue of COVID-19 pandemic. This is a tricky point, actually, because of the FETP value. It could, in a way, advocate and manage to get financial support from various partners and donors, and using the right message, I think, for advocacy. This is something other public health programs can benefit. However, on the other hand, we need to ensure the sustainability and continuity of this program, and not to be solely dependent on external support. And this is why now we are all talking about institutionalizing the FETPs within the Ministry of Health or other related agencies within the FETP. I think one of the success factors behind this program is the strong network that stand behind this program. And maybe most of us are familiar with the regional network, including, of course, MFNet, AFNet in Africa, Asian plus 3, Central America, South America, Southeast Asia, Europe, and at the international level, we have the TEFNet. The role of those networks is to promote the career path of the residents, assure the quality of the training, provide CPT opportunities, coordinate efforts and support to those programs, as well as, of course, supporting its continuity and sustainability. But also they add value to the program by providing a space for those residents from all around the world to come together and share their knowledge, their experiences in regional conferences, workshops, and other means of communication. So I think this is another unique feature of the FETP that other programs can benefit. And to maximize this value of the program, recently in 2021, 14 of the international public health leaders, they grouped together and under the strategic leadership group, and developed an FETP enterprise supported by 8 specialized working groups. So this is what is FETP and how it works. But considering all those factors, what have we gained from having FETP? So as you can see, the countries in green, they have their FETPs. They are all over the continents. And by 2022, now we have 92 FETPs in 165 countries and territories worldwide, with more than 21,000 graduates, including 3,000 graduates of the frontline in Africa and Eastern Mediterranean region. Those residents and graduates have contributed to evaluation and development of disease surveillance with more than about 9,000 studies and projects. They have investigated more than 14,000 outbreaks and responded to public health emergencies, as well as producing more than 11,000 presentations and almost 4,000 peer-reviewed journal articles. Also, another, I think, advantage of this program is the retention of its graduates. And in recent studies conducted by the US CDC, that 80 to 100% of the FETP graduates continued to work for their ministries of health or equivalent agencies. And similar results were obtained from Central America and Africa. The impact of the program extend beyond graduating numbers of residents, but also this program actually supported the health system in the countries where it is implemented. As many articles now are published from all around the world. The most significant contribution, their recent contribution to responding to the COVID-19 response, where 65 FETPs were directly involved, and also beside the COVID-19, they have their contribution in other major events. And this is why maybe the WHO now codified in the IHR M&E framework. As I mentioned earlier, FETP is not just a training program. Actually, it graduates leaders, and this is what we need in our health systems. We don't want to have highly technical persons lacking the leadership and management skills. So this FETP also contribute to the development of those leaders, and now we can see those graduates having leading positions at their ministries of health as well as other agencies, whether the UN agencies, international NGOs, and many other similar bodies. The evidence that support the positive impact of this program, I think now available, but just those are some examples of the contribution of the FETP graduates, whether in the IDSR in Africa, and some countries actually change their policies based on the outcome of these programs. But still, the question is there, how to retain our graduates, whether from the FETP or maybe other public health programs. And this is a problem that actually our countries, especially in this region, is a major challenge for some of those countries. However, FETP showed us that one ways to ensure this retention is through the ownership of this program by the Minister of Health. We need to come up with a well-defined career pathway for the graduates, maybe also the competency-based nature of this training could contribute to this retention. Some countries also link it to a dual degree where they provide the graduates with a master or diploma degree in addition to the FETP certificate, maybe this, designing new appropriate positions for the graduates, as well as opportunities for continuous development, including research opportunities and others. Seeing this impact of FETP, maybe we would like to ask ourselves how to extend this impact to include other public health training and capacity building programs. I see it as the FETP as an effective workforce development strategy, either directly or indirectly, as we will see. And definitely it will directly contribute to the improvement of the surveillance as well as the response capacities of our countries. One of the areas that we can learn from the FETP is that our training programs, education programs should stand on a competency framework. And now many agencies, including the WHO, our regional office here in EMRO, and working on the development of this, as well as many countries in this region. Also, one way of how we can extend the impact of the FETP to improve the other public health program, training and education programs is the blended modality that INFINIT with partners developed over the last few years, including by introducing the online component to this program, the mentorship model that FETP follows. I think this can be very useful and applicable to many other or similar program, the exchange program, where the residents from different countries, they visit and exchange their experiences and knowledge with their peers in other countries. And one important component that, at least for me, I see always forgotten is the training need assessment. Do we do proper training need assessment before launching our training programs, our education programs, or the university or at the Ministry of Health or maybe other institutes? FETP tells us that a training need assessment is an essential step before deciding on establishing new programs or expanding in existing programs. Issues like sustainability, networking graduates associations, linking the program with the continuous professional development for the graduates, transformational training. I think maybe Dr. Sheikh can touch on this as well. And finally, how we can follow this model of having a collaborative and smart partnership to support those programs. So my final message and recommendation is that by investing in FETP, we are going to contribute to build the capacity of our national and global health workforce. Thank you, Dr. Faiz. Back to you.
Thank you, Dr. Haytham, for this very insightful presentation and highlighting the value of FETP in advancing really essential public health or essential public health workforce in the region. And I think the achievement that had been made over the last few years, probably 10 to 12 years since from I think 2010. Before that, we had in the region only 2 programs. Nowadays, we have programs in almost all the countries in the region. So this expansion horizontally and vertically, hopefully it is going to make a change if it is not already done. And we are going to highlight this probably later on in our Q&As. Now, our third presenter for today is our colleague, Dr. Sheikh Badr, and Dr. Sheikh is the chairperson of the Community Medicine Council of the Arab Board of Health Specializations. And Dr. Sheikh is a public health physician, a health workforce expert, and a strategist with over 20 years of service in senior position related to health system and the health workforce in Sudan and beyond. He has recently been selected as a member of the advisory board of the International Academy of Public Health. He is also a member of several prominent regional and global health system and health workforce networks. As a WHO health workforce consultant, Dr. Sheikh produced several reports on health workforce strategies, organizational development, and educational systems. Dr. Sheikh has also been deeply involved in national, regional, and global health workforce initiatives. Dr. Sheikh is going to address the transforming public health education to address workforce challenges, the International Academy of Public Health innovative model. Dr. Sheikh, you have 20 minutes for your presentation, and later on we will conclude and with the questions, inshallah. Please.
Thank you so much, Professor Faris. I'm glad to be here among colleagues to present on the public health capacity, which is actually a timely and a topical issue. I do really thank INFINIT for providing this opportunity. I will be sharing my screen. So I hope it's showing now.
Yeah, please.
Yes, probably we listened to very fruitful and optimistic presentations from Professor Middleton and Dr. Haytham on the global public health landscape, and also on the successful case of field epidemiology training. From my side, I will probably put in more of a realistic picture around the challenges of public health workforce capacity in the Eastern Mediterranean region and the opportunities we see.
Sorry, Sheikh, if you allow me just to make your presentation in the presentation mode, please.
It's already.
Yes, click that.
Okay.
Yes, perfect, thank you.
So I will also discuss the opportunities and the way forward. So my presentation will address some clarity around the Eastern Mediterranean region context in relation to public health. And then we'll discuss public health workforce capacity, what's happening in terms of the pros and cons, what are the main remaining challenges, and what are the opportunities that we currently have. So the EMR is 22 countries with, I guess you know that the situation is very diverse in the region. And earlier, the WHO Regional Office for the Eastern Mediterranean has classified the countries as three-tier classification in terms of health system, with the Gulf countries representing a group, and then some middle-income countries in the middle group, and then some countries in the region, lower-income countries or countries in conflict, representing the third group. However, the region has increasingly witnessed instability and conflict, and probably nearly half of the member states are in some way or other in conflict situation. We also see the double burden of disease and the effects of climate change, and of course, the global health security issues. And also in our region, we have a number of limitations on public health capacity. I will discuss some of these, and also the COVID-19 context and its implications on public health. The WHO Regional Office has set like 7 regional priorities for the program of action. And among these is the health workforce, signaling the importance of developing the competent, the adequate, and the effective health workforce for the region. Also, we have the Eastern Mediterranean Regional Essential Public Health Functions. Professor Middleton alluded to these in context of other essential public health functions and operations across the globe. So in the Eastern Mediterranean, we have, and these are more or less, similar to what is set in other WHO regions, probably different wording, different dimensions, but they actually include the essential dimensions that should be observed in developing public health capacity. In terms of discussing the regional situation, I put in this simple framework of looking at public health workforce capacity from 4 angles, from the educational domain, the regulation for public health professionals, the practice, and the networking in terms of associations for public health. So in our region, in terms of public health education, we have a number of positive dimensions in terms of rooted schools of public health. We have actually a number of public health schools that are outstanding in the region and have been providing, developing the health workforce in the region in different public health domains. We are witnessing also increasing potential in terms of the number of postgraduate public health programs. And Professor Iman from AUB and colleagues have published a paper showing increasing potential in public health programs, either within medical schools or standalone schools of public health and health sciences. Also, we are increasingly seeing models of undergraduate public health education. And actually, this is a very pleasing dimension where candidates and students study at the undergraduate level for a public health degree. And this has been in existence in some countries in the region, including my country, Sudan, where this has been a long-standing practice, but it's now seen in other countries of the region. And I think this should be seen as a positive for public health. There is some rising popularity for public health programs in the region. And also there is the FETB program. Dr. Haitham presented on that. I regard it as an extremely successful program for public health capacity in the region. We are seeing also new emphasis post-COVID-19, if we can use the word post, because we are still dealing with COVID-19, but I think it has created a number of lessons and opportunities for public health. Also, in terms of community medicine, the programs in the region are increasing. The Arab Board of Health Specializations, where I am currently leading the program, is expanding the program. And a number of countries, including in the Gulf area, are establishing community medicine programs. And community medicine is more or less public health. On the other side, we still have issues with educational capacity for public health training in the region. And when you compare with the clinical training and clinical specialties, still public health needs a lot. Just to give you an example, in the Arab Board of Health Specializations, the candidates in community medicine represent only 1% of the total number of trainees under the board, which amounts to 25,000 trainees. Most of them are in obstetrics, in clinical, in internal medicine, in surgery, and in other clinical disciplines. So still, we need to address the educational capacity. We need to address funding and resources, and this imbalance between public health and clinical education. And also this issue of academic education. While we are having good programs at master's level in different universities, I think the absence of professionally oriented public health training in the region is something worrying. And I think that needs to be addressed. While we see in clinical medicine that the region is largely embracing a clinical residency training program, in public health, we are still lagging behind. So I regard this as an important area. The CPD gap in public health is also there and evident, compared also with clinical disciplines, where you find active clinical associations delivering conferences, CPD opportunities for physicians in different clinical specialties. But when it comes to public health, it's largely ad hoc. Now moving to public health workforce regulation. Of course, one of the positive dimensions, the public health profession is regulated in many countries, and the MPH is largely recognized in employment, and also sub-disciplines in public health are recognized. However, on the other side, there are still issues with licensing status for public health professionals. And these are undermined compared to the clinical disciplines, where you have clarity about the licensing status and privileges. But when it comes to public health, unfortunately, research degrees such as PhDs do not count in classification by regulatory bodies. Therefore, you find public health professionals usually are not in a regulatory or licensing status that commensurate to their clinical counterparts. And this has got a number of negative implications on public health professionals. In terms of public health practice, of course, the Eastern Mediterranean region is very rich as a field of practice, and this is testified now by the evident success of the field epidemiology training program. And we have increasingly are seeing a number of specialized programs and centers and projects on different dimensions of public health, including, for example, occupational health, epidemiology, and other dimensions. And there is an emerging health system focus on improving public health practice. On the other side, however, public health practice in our region is overshadowed by the powerful clinical practice. So you find in different countries in the region more focus on clinical practice in terms of preparing protocols, guidelines for clinical practice, and more emphasis on clinical practice in comparison to public health practice, which is less defined with less, number of protocols and standardization. There are also issues with the practice environment for public health professionals, which might not be the best practice environment for such an important discipline as public health. Now, getting to public health workforce networking, we have some national public health associations in some countries of the region, and still some countries are establishing their associations. At a regional level, we have probably an Arab Public Health Association, which is evolving and trying to bring professionals from different Arab countries. And as you know, the Arab countries constitute the majority of the Eastern Mediterranean region member states. We are seeing a number of conferences and events. And in the coming months, there is a conference for the Arab Public Health Association. Some of you know that this is going to be in Cairo. But on the other side, largely the association power for public health in the Eastern Mediterranean region is inadequate. And I just browsed the membership of the World Federation for Public Health Associations, and I found that from our region, only 5 national associations are members, while we have 22 countries. So there is a gap in this area. And I think a number of countries would need to establish their national public health associations that are multi-stakeholder and broader, not only physicians, because to be a member in the World Federation, you have to be a multidisciplinary public health association. And that's wise, actually. There is lack of effective networking for public health and inadequate experience sharing at the regional level in public health. I know that there are some calls to bring together public health schools in the region and other networks, but still it's to materialize. If we speak about the remaining challenges, the main issues, we have issues with public health education coverage, both horizontal and vertical. Horizontal in terms of the MBH itself, or general training in public health, and vertical in terms of the different disciplines, the expanding disciplines, as all of us know that public health is now differentiating in different disciplines that they are standing by themselves as areas of specialties. So we have limitation in our region. We need more of expansion horizontally and vertically. The second important challenge is around professionalizing public health education. I think this, in my opinion, this is a major challenge in this region. It's unacceptable, in my opinion, to until now not see a mature residency type or practice-based training in public health in this region. While we do value very much the academic training, but we think that the practical dimension is highly called for. Also, addressing the regulation status problem, and I already alluded to this. I think public health, to have its deserved status, it needs to be regulated in the highest tier of regulation, hand in hand with the clinical board certificates. Also, public health practice in our region is largely non-standardized. It's mainly ad hoc when you go to the field in public health and when you visit programs, different programs in ministries of health, there is rich experience, but it's not standardized as a training and a practice side. Capacity for networking and association, I already discussed this. The image and career progression for public health. Image in public health is a problem in this region. And we have the harmful comparison with the clinical disciplines, where they have clear passes and they have actually professional and economical reward. And when it comes to public health, people are seeing it as undermined. We still, as public health professionals and leaders in this region, we are still short of convincing young generations to embrace public health discipline in large numbers. And I think we remain to address this challenge. Public health and community medicine, the relational challenges, I mean here the issue of medicalization of public health. Public health started in the realms of medicine, and physicians were dominating public health. But it's evident that public health is multidisciplinary, and we need the collective action and power and presence of different professions. But in this region, it's still there is issues around the relationship of community medicine with public health, and our professional training in public health is largely now geared to training physicians with different specialty boards, but not other health professionals. The opportunities we are seeing in our region now, I would count undergraduate public health education movement as one, and also the existence of public health institutes in a number of countries that are supporting training and capacity building in public health. Also, we are seeing, as I already said, expansion of postgraduate public health education capacity in the region. And we are also seeing some important regional initiatives to scale up public health capacity. And I would specifically mention the International Academy of Public Health, IAF, which is a regional organization that dedicates its mission to raising the profile of public health and professionalizing public health education. And in my opinion, IAF is a very important initiative that most probably will succeed in this region to lead the transformation together with other public health organizations and schools in the region towards expanding and professionalizing public health education. Also, we are seeing expansion of community medicine programs, as I mentioned, and the post-COVID momentum in favor of public health, and that's seen in more of dominance of the concepts of global health security, One Health, and all these issues coming in favor of public health. And I will just discuss some few issues for the prospects and way forward to conclude the presentation. In my opinion, to address public health capacity in the region, we need system thinking approach. It's not only through education and not only through practice or regulation or association. It should be through all of them, the 4 pillars. So when we think of expanding public health education, we should be also addressing the practice setting and addressing the regulatory prospects and addressing also the networking prospects. And we need to see the opportunities provided by the pandemic, which, as I mentioned, is more highlighting more advocacy for public health and its importance. We need to work hardly as public health leaders in the region to raise the profile of the public health profession. I think this needs deliberate action. We are all proud of being public health professionals, but we need to convince younger generations. And also we need to transform public health education. It's not reforming it, it's transformation and professionalizing it more and more. And we need to capitalize on innovations and information technology potential. And we need more of regionalization in terms of exchanging and networking and leading from the regional perspective. And I'm glad that there are now movements in terms of the International Academy of Public Health and also in terms of WHO, EMRO. And I would like here to note the important work in EMRO led by Dr. Gulin, who is a coordinator for health workforce development, in developing the competency framework for public health, which is meant to support the delivery of the essential public health functions for the Eastern Mediterranean region. And this is a highly needed work and is evolving, and it will soon be coming out. In the International Academy of Public Health, we built on this, and we are also developing a competency framework specific to public health education. And this will complement the work of WHO EMRO in providing a framework to improve and transform the curricula for public health education in the region. This is also work in progress, and it will come out for regional consultation and for validation with international agencies. Professionalizing public health education is an important dimension. I think the competency framework movement will contribute to this. Also, we need to seriously think of the practice-based education. And I'm glad that the International Academy of Public Health is launching a project on public health residency, where work will address standards and requirements for the practice-based approach in public health education. And there is going to be a process and procedure for accreditation of training sites for the purpose of public health education and training. The International Academy of Public Health is introducing a dedicated scientific committee on public health education, similar to what is done in medical education. That's the science of how to teach public health education and how to develop the field of public health education. And this is quite innovative. Last but not least, we need to link up to practice and regulation. I mean, linking up public health education, professional education to practice and regulation. And in that, what is important, in my opinion, is trying to introduce a higher professional degree in public health that would allow public health graduates to be recognized by regulatory agencies in the countries of the region as consultant level, similar to what is done with graduates from clinical disciplines who obtain board certificates. They are classified as consultants. We need something similar for public health, because currently MBH as a gold standard, it falls short of this status in classification of public health. So we can think of professional degrees, probably a doctorate in public health or other board and residency type training and education. Finally, there is a need for enabling environment, of course, for all this to happen in terms of funding and resources. In terms of the health system commitment, we are seeing lots of commitment on payback from countries in the region to public health, to primary healthcare approach and to these issues. But sadly, the practice on the ground in several countries is much geared toward hospital care, towards clinical medicine, and towards subspecialties. Nowadays, people are moving to super specialties in clinical medicine, in surgeries, and in other disciplines. So the health system commitment to public health needs to be practiced rather than stated. And that should be supported by political support and again by regional patronage and regionalization to strengthen public health in the Eastern Mediterranean region. Thank you so much.
Thank you. Thank you so much, Professor Dr. Badr, for this great presentation, indeed, as usual. And really, we are happy today to have three excellent presenters and three excellent presentations, really very inspiring. And they raise a lot of issues which are very, very practical indeed. And to me, and I may suggest to Infinite, we are in need to have another session just to dive deeper, really, and make some sort of find the section of the points that have been raised in order to reach to some specific and tangible activities, how to address the problems that we have, how to pinpoint the strengths that we already made over the previous years. And this is definitely will help a lot in achieving the our objectives and our goals, as mentioned earlier in our introduction. Unfortunately, we have only, I think, 9 minutes till we conclude, but we received a lot of questions indeed, but one of the questions is raised from Professor Zuhair Sibai. I think this is a burning question regarding if any of you colleagues have any idea of any institution or a body that can accredited public health diplomas given in Arabic language. Do you have any idea about that? Professor Middleton, did you hear about any body that accredited public health diplomas given in Arabic?
Yeah, I answered it in the Q&A, but yes is the short answer, and I think Hitam can give examples of diplomas of his that have been accredited. So do get in touch with Afia, please, and we'd be delighted to try and support you in that.
Thank you so much. And another point that had been raised by Dr. Youssef, and probably Dr. Sheikh can address that, about the performance or the role of the FETPs in achieving the universal health coverage. What do you think, Dr. Haytham?
Yeah, yes. Again, short answer, yes. And but we need here to be careful when it comes to FETP. We have seen in the previous years that increasing demand on the FETP as an effective program, and we have seen many new modules, suggested modules, many new competencies. My only concern is that we may lose the flavor of the FETP. What is FETP? But again, short answer, yes, it can directly or indirectly contribute and be instrumental to universal health coverage, as well as other public health initiatives and projects.
Yeah, thank you. I think you all highlighted the importance of the professionalism in our work. Otherwise, it will be just like many academic degrees, which at the end, they are not doing the job recommended on the ground. So I think this is very important, and we have to keep the direction and to keep focus on the professionalism, and other aspects that Professor Middleton had highlighted. Periodic assessment, for example, evaluation, code of conduct, etc., etc. All these should be considered. Thank you for raising all these. A lot of challenges have been raised, and you, Dr. Sheikh, you very nicely pinpoint these challenges in the region and elsewhere, indeed. But some specifics really for the region, which is, as you mentioned, usually people working in the area of public health, to be very honest, they look from the general public is not as they look to the other discipline in health and in medicine. How can we correct that? What activities that the government, for example, other public agencies and other agencies, for example, what can we do in order to break this problem and break this cycle?
Thank you, Professor Faris. I think, yes, I agree with you. This is one of the major challenges for us as public health professionals. My opinion and my experiences is starting from within. I think always the public opinion can be shaped and reshaped. But the major crisis of public health in this region comes from within the health system itself. If the health system, and in particular health system leaders, are not convinced to support public health, I think that would create a gap. And while we do very much respect our clinician colleagues, and we think we need the service of different clinical disciplines, and we need the service of hospitals and subspecialties and super specialties. But the problem is how to balance these issues with public health, and how for our health systems to be rational in implementing an approach which is cost-effective to healthcare, addressing population health through a wider lens, and addressing the cost-effective interventions while not neglecting the clinical disciplines. As I mentioned, professionally, the lack of respect that we see for public health professionals come from within the health system. For example, as I mentioned, the situation and regulation. So you have 4 or 5 qualifications in public health, and when you go to your medical council or regulatory authority, you are not classified at a consultant level. And I think this is a great caveat in my opinion. And it signals your financial reward, your professional status. It all depends on the regulation and how you are viewed. So I think even from within the public health community, we need to address this by professionalizing public health education, by taking public health education to higher levels, and not just graduating people with master degrees. While the master is instrumental, but as all of you know, master signals a sub-qualification in this world, because people look up to doctoral qualifications, and when it goes for higher qualifications, it goes professional. So this is a dimension. And the last thing, in my opinion, is the role model among public health professionals. It is sad in our region when we see people in community medicine and in public health who are not convinced by their specialties. And I'm going frank here. This damages actually the profession. But I highly value the role model. If you are a role model in public health, younger generations can follow you. And I think Haytham, and maybe if there are colleagues from Sudan here, would agree with me that we were attracted to public health disciplines, not because we were not able to pursue clinical medicine, but because they were role models that we followed. And in that manner, I think we can raise the profile of the profession. Overall, I'm optimistic. If we join hand and work together at the regional level, public health is expanding and is seeing more popularity, in my opinion.
Just to echo what
please go ahead.
Dr. Badri says there, clinical practitioners save lives one by one. Public health practitioners save lives in millions. It's the best job in the world, and we should all be extremely proud of it, and we should all be bigging it up in every opportunity. Thank you.
Thank you. Thank you so much. This is really great. And one of the areas that have been raised very nicely, again, the cost effectiveness, as you mentioned, Dr. Sheikh here. Because I think we, in many countries in the region, we concentrated in our public health education on the basics and the standards. But for example, the area of health economics, you rarely find health economists in some countries in the region, which is very important. This is going to convince you mentioned the convincing the leaders. How can I convince the leader if I don't show the leader that prevention, giving the vaccine, for example, is going to $1 in vaccine is going to make 34 or 43, really $43 as a gain. So by having these values, I'm sure we can persuade the policymaker, the leaders, and after that, they are going to appreciate the value of the public health work. I think this is something that we need to consider later on in our discussion. And the role model that you highlighted also is very, very important. I think UK did a great job in this regard, and comparing to many other countries, even in the Western societies in this regard, and appreciating the value of the public health work, workforce in general, and having their standard and type of the training is really the one that we are looking at here in the region. Honestly, they are not much higher than we look for other Western countries, because we can see that the standard of vocational and professional training in the area of public health is more evident in the UK health system than others. I think there are a lot of questions, but unfortunately, I don't think we can cover them. But I may ask my colleagues if they can respond to these questions later on. They can write the answers for the remaining questions, and we can disseminate that later on with all the colleagues. And allow me at the end to thank Professor Middleton, Dr. Sheikh, and Dr. Haytham for your great presentations, and thanks to all the audience for their having them with us and for their questions as well. And thank to Dana and her colleagues for arranging this webinar, and hopefully we will see you again. And in a similar, really, we need another webinar on public health workforce to, as I mentioned, to have a deep dive. Thank you again, and wish you a very good day. Bye-bye.
Thank you.
Bye. Bye-bye.